So yeah, as Ruth said, today I'm going to talk about what made up the bulk of my PhD at the MRC CSO Social and Public Health Sciences unit at the University of Glasgow. And this was an evaluation, a public health evaluation of Scotland's baby box scheme using linked administrative data. Yeah, so it's worth saying I've sort of kept this hopefully straightforward and understandable. But if anyone is interested in more detail, then feel free to ask me about it at the end. So yeah, how do I skip? Oh, there we are. So a bit of background. Baby boxes have seen an increasing international uptake in recent years, and most of these are inspired by the Finnish baby box, which was originally introduced, released in its sort of basic form in 1938 to disadvantaged mothers, and later universalized to all mothers in 1949. The Finnish baby box received sort of popular attention in 2013 with an article published on the BBC titled "Why Do Finnish Babies Sleep in Cardboard Boxes?" And it's interesting to note that there were no sort of baby boxes in operation in the UK prior to this article. Baby boxes have often been introduced in relation to claims around infant mortality and sudden infant death syndrome. However, it's worth stating that there is no evidence currently to date to suggest that there is any link between baby boxes and these outcomes. And more generally, there's actually very limited evidence on the health effects of baby boxes, which is where I came in. So my focus was on Scotland's baby box scheme, which was introduced on the 15th of August 2017. Alongside the Finnish baby box, it is currently the only other baby box in operation that is universally available to all parents, unconditional and non-commercial, and also government operated. Registration for the box occurs during pregnancy, and then it's also received towards the end of pregnancy. The box is a cardboard box that contains a foam mattress that is intended for infant sleeping. Then it also contains various items that are useful for the initial months of birth, clothes, toys, that sort of thing. Yeah, it also contains information on various things. So this is of interest to public health and health inequalities. And it can kind of be viewed maybe as an in-kind transfer or transfer of material resources with an equivalent cost, which could potentially save parents money. It could also be viewed as an educational intervention, given the information available, and it could also be viewed as an engagement tool to sort of be used to initiate conversations with healthcare practitioners. So looking at the baby box as a candidate for evaluation, it is actually quite a good candidate for evaluation because it has a clear point of intervention that clearly demarcates between what could be viewed as exposed and unexposed populations. Is a population-wide exposure, being all parents in Scotland. And there's a sort of lack of any antecedent policy. There is no sort of similar policy that might obscure any effect of its introduction. And also, being blessed to be in Scotland, there is also available and relevant administrative health data. So my approach to evaluation was actually fairly simple. I just wanted to model changes in the step, which is the level, I guess, of an outcome trend, and also the slope, which is the change over time of an outcome trend. My population of interest was all live singleton births in Scotland. And I looked at a period of 4 years, 2 years either side of the box, from the 17th of August 2015 to the 11th of August 2019. And I linked health data from various sources using the Community Health Index number, which is a unique patient identifier in Scotland. My full study population across these 4 years was approximately 180,000 infants and mothers. On the right-hand side here, this is just a basic illustration of my data sets that I linked. So this was, originally I identified the study population and data for maternal admissions, and I linked this to child health data and also general admissions data. So I was interested in various outcome measures. I wanted to take sort of a broad approach to the evaluation. So this included infant and maternal all-cause hospital admissions. I viewed this as sort of a general measure of health. Then I also had measures for infant exposure to tobacco smoke, exclusive breastfeeding, and infant sleeping position. The latter three are tied to the baby box in relation to both the information that was provided, but also the sort of intended outcomes that were outlined in an evaluability assessment a few years ago. And then I was also interested in differential effects and possible effects on health inequalities. For this, I looked at maternal age groups, and then also I used or stratified the population by the Scottish Index of Multiple Deprivation, which is an area-based measure of deprivation and can be seen as also a measure or an indicator of socioeconomic position. And then it's worth stating, because I'm aware I'm not speaking to people in public health exclusively here today, that my parameter of interest, so this is the output of the model, was relative risk. And it's actually pretty straightforward to understand. So a relative risk of 1 sort of indicates that there was no change between exposed and unexposed groups, or between the post-intervention and pre-intervention period. Relative risk greater than 1 indicates an increase in risk, and less than 1 indicates a decrease in risk. And then I used 95% confidence intervals to sort of measure the precision of these estimates, or give an indication of the precision of these estimates. So onto results. In general, the baby box was not associated with any change in infant or maternal all-cause hospital admissions, either at 6 or 12 months postpartum. It was also not associated with any change in exclusive breastfeeding 10 days postpartum or infant sleeping position. However, amongst young mothers aged 25 years and younger, breastfeeding actually increased by 10%, although this association could be spurious because it was the only subgroup that this effect was observed. But it's still worth noting because breastfeeding exhibits a gradient by maternal age, and young mothers, the prevalence is the lowest in young mothers. So this could have possibly important implications. Next, I want to talk about results relating to infant exposure to tobacco smoke. First, I'll direct your attention to the graph or the plot on the right-hand side. And what this shows are the data points of the outcome trend over the 4-year period, which is the week of birth, and it's aggregated by weeks over this 4-year period. And then the red line is the modelled trend across this period, with the grey box indicating the period or point from which the box was introduced, and the white box, the sort of unexposed group that didn't receive the box. And you can see there is an immediate decrease in this predicted trend. And this is a relative decrease of around 10%. So a decrease in infant exposure to tobacco smoke. There was no change over time, but in absolute terms, it's actually quite, or relatively small. It sort of equates to about 1.3 per 100 people less being exposed to tobacco smoke than would have been expected around about a month after introduction. Related to this, I also looked at subgroups by deprivation for this measure. And interestingly, this effect size was only present in the first 2 and the 2 most deprived groups. It was also present in the least deprived group, although the precision of this estimate is not as precise. So this may indicate a possible beneficial effect on inequalities. And the reason for that is because looking at the right-hand table, you can see the mean prevalence across the different SIMD quintiles in pre and post-introduction periods, and you can see that there's stark inequalities. For example, in the pre-introduction period, almost a quarter of infants were exposed to secondhand tobacco smoke. That's versus a 20th in the least deprived. And you can also see that the difference is greatest in the most deprived quintiles. So there's possible evidence here of narrowing of socioeconomic inequalities. Moving on to a related measure, these are estimates for primary carers currently smoking, and it showed a similar decrease of 9% and a similar decrease in absolute prevalence, about 1.6 per 100 individuals. These were on the same farm, so it could just be, that might be why they're so closely related. Obviously, this is an unexpected and interesting effect. So I was also lucky to have a few outcome measures of maternal smoking during pregnancy and at booking. And I sort of used these as what we would call negative controls. And these are basically outcomes that are very similar to our other outcomes of interest, but we don't expect to be affected by, for example, the baby box, because these came prior to receiving the box. And yeah, if we saw a similar effect in these outcome measures, it would be an indication of possible bias, but we actually don't. And it seems that, there was not really any meaningful change in either of these estimates between the sort of pre and post-intervention cohorts. So that sort of lends itself to supporting the previous effects that I've shown you. So strengths and limitations of this evaluation. This is the first outcome evaluation using linked administrative health data of any baby box that I'm aware of. The data offers near complete population coverage, and the methods that I used are sort of robust methods of causal inference. Limitations are a sort of lack of long-term measures. It's not clear if indeed these are effects, how long they last for. There's also possible unaccounted reporting bias for tobacco measures. And then for the association for exclusive breastfeeding among young mothers, there's possible history bias. For example, other policies in operation in Scotland that target young mothers, such as the Family Nurse Partnership, could also be responsible for this effect. So in summary, Scotland's baby box may have reduced infant tobacco smoke exposure, but I should stress that these are actually are very preliminary findings. They've not been peer reviewed yet. There are a few questions that arise from this. Is it indeed a causal effect, or is it just an association? If it is an effect, how long does that effect last for into the postpartum period? What are the actual mechanisms driving this effect? I have a few ideas, but it's not quite clear. And then also, if this is indeed effect, is it a sort of cost-effective way to intervene on secondhand tobacco smoke exposure? And then also, the box did not have any effect on hospital admissions, breastfeeding, except possibly among young mothers or infant sleeping position. So the implications of this research, Scotland's baby box may have some benefit for infant health, although these benefits are probably not as wide-ranging as was hoped. There's also a question of generalizability. Many baby boxes are in operation, but these are actually quite heterogeneous. As I said, Scotland's the only baby box alongside Finland at the moment that offers a universal, non-commercial box, although Wales and Ireland may be following soon. But many of the boxes in operation, for example, in England, involve sort of commercial healthcare body partnerships and are different in terms of scale and what's offered. It's also worth noting that there are stark inequalities in these outcome measures, as I showed you in smoking, and this may indicate that actually socioeconomic conditions, for example, the distribution of resources in society, may be more worthy targets for improving infant health. And then a sort of final thing to note is that outcome evaluation is pretty straightforward and inexpensive and important for understanding the health impact of policies. So it's definitely worth considering when introducing policies to build in similar evaluations in future. I think that's it.